So first, I'm Dr. Arthur Jenkins. I'm a neurosurgeon by training, fellowship trained spine surgeon. Have done 17 years full-time faculty at Mount Sinai, doing everything from the minimally invasive spine program to the tumor, director of the tumor surgery program there for many years. And I went into neurosurgery for the same reason many of you did. I wanted to go into a field that would not be all figured out by the time I retire. And so far that has been great. I went private about 6 years ago, started my own shop, got tired of hearing that's not the direction we want to take the department. And so now I take my department wherever I want it to go. I have my own research team, and Jack O'Donnell is my research coordinator. Cameron Harvey is my scribe/research assistant. That's so nice being in private practice. You want to scribe, you get a scribe. You know, you don't have to go through 12 different administrators who say, if we do that for them, we have to do it for everybody. But anyway, so also as a private practitioner, one of the things that, and as an out-of-network private practitioner, you know, I'm not going to be doing 500 microdiscs or 100 T-lifts in a year, so I'm not going to be publishing on 1,000 of these. Instead, I went into some of the areas that are, I would just consider poorly understood, areas where it's like the room is filled with a candle instead of with a lot of spotlights. I figure if I bring a flashlight to that room, I can make a little bit more of a difference than I can trying to find a better way of robotically doing a T-lift. So one of the areas that it came across is hypermobility related autonomic dysfunction. And I'm going to get to just why that seems as crazy as it is, because these are patients who have mostly been marginalized. Nobody's really taking them seriously. And actually, there are biomechanical things we as surgeons can do to make a difference in their lives. So as far as my disclosures go, I have no material disclosures for this talk, other than I make money doing spine surgery, so take that with a grain of salt. But I have other investments in biotech companies, unfortunately, including one of I just got issued a new patent yesterday, yay. So I now have 6 patents, but I'm not making any money off of that, sadly. And if the questions come to it, we may be talking about off-label use of BMP, but that's not part of the actual talk itself. So what I'd noticed was a lot of the patients that I was seeing for other conditions, whether it was thoracic outlet syndrome or Lodi syndrome and other forms of hypermobility, they would have a history of hypermobility, and the easiest way to check to see if somebody has hypermobility, you do this on a telemedicine, you can do this in person, just ask if they can push their thumb towards their forearm. I cannot, but many of them can. And if you have that degree of hypermobility, there are others, there's the reverse namaste, there's a whole series of measurements, you can look this all up online. Ehlers-Danlos syndrome, hypermobility type is the most common cause. Marfan's, other types of non-specific hypermobility. This was a common theme running through my patients, and then I would also talk to them and say, by the way, I also have these other symptoms. And putting all of that together, I realized there's actually a whole syndrome here. There are some people who understand it, but they don't. They're also marginalized a little bit, and so I want to try to bring this a little bit more into the mainstream. There are entire Facebook communities dedicated to these patients who are basically frustrated because they're not getting adequate treatment. There are 36,900 just in one EDS Facebook group alone, and so there's a lot of undertreated patients out there. One of the biggest symptoms that they get is this disruption of their autonomic function. And so this autonomic dysfunction is part of the yin and the yang of these sympathetic and parasympathetic nervous systems. And POTS, P-O-T-S, postural orthostatic tachycardia syndrome, they stand up and they either pass out or they nearly pass out. That's actually not normal, but a lot of patients, they go through these extensive pharmacologic treatments and therapeutic treatments, but there's actually, for some of them, a common biomechanical pathway. And sometimes it gets so disparate that people they give up, they don't want to deal with something that complex. But it's actually a biomechanical problem. You look at the anatomy of the cranio-cervical junction, there are the artery nerves and veins in the area are highly subject to extraneous or extra rotation at that junction. There are a number of different ligaments, and actually what I suspect is one of the issues is the accessory atlantoaxial ligament is either absent or dysfunctional, and that seems to limit the ability to turn. And so it's both a vascular and a neurologic problem from hypermobility in this area that's subject to such high strains. In engineering terms, we talk about the 6 degrees of rotation, XYZ pitch, yaw, roll, in aviation terms as well. But in spine, we talk about spondylolistheses in anterior, posterior, and lateral, distraction, compression, flexion, extension, lateral bending, rotation. Now, traditional methods of instability, if you don't see it on the neutral and the straight ahead flexion extension films, oh, the spine's stable, right? Nothing else to do here. When you look at rotation, we also look at the classic Punjabi and White definitions, but in more recent terms, in more recent times, we've been seeing articles coming out that describe range of motion can be as much as 45 degrees. What they don't mention in those reports is they're including abnormal hypermobile patients in their spectrum. And so they're describing, and if you take a spine model and you try to turn it, absent a fracture, you cannot exceed 45 degrees of rotation in C1-2. But we also know that at 36 degrees, you start to occlude the vertebral artery. At 40 degrees, you completely occlude it, and that's when Bow-Hunter syndrome can come about. So the transient and intermittent hyperrotation can lead to the following symptoms, and this is, I've been seeing this in these patients. One college student noted that when she was walking down her campus, she was fine, but she was walking in her campus with a friend, she would be getting all these symptoms. And I said, were you looking at your friend when you were talking? She's like, oh my God, yeah, it's with my head turned that I get these symptoms. So you can get sympathetic dysfunction from a repetitive stress on the sympathetic nerve. And that goes back to the anatomy where the sympathetic chain at C1, C2 runs up the lateral aspect. So like a lever, the more lateral it's located, the more rotation will impact it, and you get a neuropraxia, a stretch injury on the sympathetic nerve. And that then can spread up through things like the Vidian nerve and other ophthalmic branches of the sympathetics and cause visual. These are patients who are actually getting transient Horner syndrome. They can have auditory problems. They get headaches. They get a lot of headaches. And they get POTS, which is written off as a cardiac symptom, but it's actually an imbalance between a hyperactive and because it's being irritated sympathetic nervous system against an unaffected parasympathetic nerve. The vascular problems are almost as bad. The jugular vein, like a Chinese finger trap, when you stretch it, becomes more stenotic. And these patients get transient idiopathic intracranial hypertension symptoms. They get headaches, they get brain fog, they get memory problems. In addition to that, the physical rotation of the C1 transverse process against the C2 lateral mass, because the veins are somewhat tethered in that area by all the different branches, will actually cause mechanical obstruction. And I have some great CTAs and CTVs showing that when the patient's head fully turned, that the jugular vein completely occludes and even the carotid can be compressed. And this is also true of the vertebral artery. Bow-Hunter syndrome is when you can get a posterior fossa stroke from essentially bilateral compression of the vertebral arteries with excess rotation and stretching and actually edge effect against the C1, the vertebral foramen in the C1 arch out distally. But patients won't come to your office saying, I have CCI. They don't. In fact, they'll tell you they have headaches. They might tell you they have brain fog, but they're probably afraid of being pigeonholed if they do. They're reluctant to tell you about their POTS because most of their other doctors don't take it seriously. They will respond to hypermobility, but some of them will actually even deny that they were ever hypermobile until you actually ask them to do the test, and they're like, oh yeah, I can do that. That's not a big deal, right? Everybody can do that. So, one, we know that EDS is a collagen vascular The EDS hypermobility type does not have any genetic marker at this time. It's most likely a combination of genetic factors that we haven't found the association with yet. But they have hypermobility, they have excess rotation. They are the ones who are hitting the 40, 45 degrees, sometimes even 35 degrees is enough to make them symptomatic. And they're frequently getting intermittent neurologic symptoms and intermittent stretch injury to these structures. So finding out what symptoms they have are critical to identifying what part of the craniocervical junction is most unstable. And some of these patients may even be unstable in only one of the joints and then subsequently develop instability at the other. We'll get into that a little bit more. So occiput C1, for the most part, it's about flexion extension. And so you rarely see any significant rotation, even in the EDS patients, at the occiput C1 level. C1-2 is obviously much more about rotation than bending and flexion extension, unless you've actually disrupted other ligaments traumatically. So we look for the patients to have, are they worse in flexion or extension, or are they worse in rotation? And they often have other symptoms. EDS hypermobility in other hypermobile patients, they're more prone to having TOS. They're more prone to having Bertolini syndrome. They're more prone to having some of these other things. And they'll frequently come in with a diagnosis of fibromyalgia. I don't know about you, but my experience is when I hear a patient with fibromyalgia, a lot of people, they don't want to talk to them. For me, it gets me interested because I know a lot of patients get pigeonholed with fibromyalgia because the doctors got tired of working them up. They're often said that they're crazy, that they have a functional disorder, and they often have congenital anomalies that are not being appreciated, such as congenital cervical stenosis. So what do we do for these patients? Well, most of the time you see somebody who comes in with a pain diagram that looks like this, you want to walk away from them as fast as possible. You want to call your junior partner in and say, I got a guy who's really good at figuring out somebody who comes in with this type of pain diagram. And the reality is very frequently a lot of this actually comes down to the CCI if you know how to ask them. Now, occiput C1 instability, the easiest marker is actually you look at the stylocervical junction. Okay, the styloid processes, the stylohyoid muscle, this is the little extension coming off the skull base on either side. This is a more normal space, and you can actually see on the soft tissue representations. This isn't a contrast study, but you can see your jugular vein right here with relatively normal size, and there's a decent gap in between. If they're too close together, you actually can get compression and flattening, and then that also gives them a leverage point to be squeezed against when it's being turned. Here you can see on the sagittal view, you can see the jugular vein coming out of the jugular foramen, and it looks unmolested in this area here. But when you look down here in this symptomatic patient, you can actually see that the jugular vein is actually stenotic in this space. And then this is a little bit of a suggestion that you've got a little bit of hyperflexion at OC1, and you see a widening of your posterior occipito-atlantal space there. And this is the styloid process coming down here. You want to see a decent gap in here for there not to be an impact of the hyperflexion on the C1 transverse process. C1-2, if you really want to get into this, you have to say 20 to 24 is normal, and beyond that you start getting into hypermobile category, and then you want to correlate whether this finding is consistent with their symptoms. But this is an example of a patient who has 43 degrees range of motion. You can see there's almost no overlap of the C1, C2 lateral mass here. This seems to be pretty unstable to me. So we did 12 patients so far with 6-month follow-up. 3 underwent O to C1. This is one of the techniques that I've used. 6 underwent C1-2 because the rotation seems to be much more commonly involved. And 3 underwent O to 2 where they had both flexion extension pain and rotation pain. What's interesting is 10 of the 12 patients underwent a collar trial. Some of them couldn't tolerate it. For example, patients with TOS just don't do well in a cervical collar, so they just wouldn't wear it. But every surgical patient who did well in a collar trial And there were patients who said to me, I'm not taking this collar off until you fix me. I don't care what you do. This is the best I have felt in years. Fix me. And so it's a clear test that works in this small series. There are other reports that have shown it's not 100%, and I never tell any patient any of the tests we do is 100% sensitive. We put all of the data into the hopper. Another test is doing a sympathetic block. Stellate ganglion block, sometimes they can go a little bit higher, whether it's the inferior sympathetic ganglion, the middle sympathetic ganglion, can all give significant impact if they get a positive response. Now, not everybody who has a positive response, well, most of the ones who have a positive response, they make this permanent. The ones who don't, sometimes we work them up further because we're still suspicious. So typically we will fuse the levels that their worst symptoms were in, but if they have both lateral bending or lateral rotation and forward flexion, then we'll do both levels. All these patients started out with head pain. This is what they look like when they get better. What's interesting is many of their other physical findings, their physical complaints, their pain in other parts of the body also got better. So when you saw that whole body pain diagram, this actually will help a lot more even than just their headaches. This is a patient. Not getting the volume here. Oops. Well, anyway, she said that first time I was able to drive in 6 years. She went from being a caregiver for her family to having to be taken care of, and then after the surgery finally went back to being able to take care of them again. And you get the idea. So in conclusion, when you see this, don't do this. Okay? Instead, think of this. And your patients will thank you, as do I. I appreciate your attention. I hope I didn't run too long. Thank you all, and this is my bibliography. But any questions before we go to hit the slopes?
That was really fascinating. Thank you for that. I have one comment and one suggestion. My comment is, because this is so radical for the way we traditionally think about this, you might run the risk of getting into the same kind of controversy of Chiari syndrome. Okay? So document your data and really do a good job. This is fascinating. My other suggestion is, in another research project I'm involved with, we recently demonstrated that the majority of venous drainage doesn't go through the jugular or external jugular system. It goes through the venous system within the canal. So you might want to pay attention to what's going on, particularly in the ventral canal during that turn, because that might be more important than the jugular.
Thank you. That's actually a great thought. Thank you.
Great talk. You know, I've actually had patients come in with collars on, refusing to take them off. And you're right. You just go, well, there's not a whole lot I can do, and they get put into this fibromyalgia category. I think when we're looking at things like this, and to speak to Rick's point, you really need objective data. And I'm wondering if a dynamic CT might not provide that objective data. So you take a group of these patients, you show it with dynamic CT, and quite frankly, I don't know if that's available, but I think it could be easily. You just have them flex, maximum flex, rotation, get those CTs in that rotation, and then take a control group. And I don't think you need many. I think you could put 10 in the experimental, 10 in the control group, and say, look, these are the objective radiographic parameters that describe this condition. Because, as you mentioned, fibromyalgia is like a trash can and just can't figure out what's going on. And, so I think a subset of these patients might have that, and you could really help them. The question is, do you need to do an occipital cervical fusion? Because now you're stopping that significant motion, and could you just get away with maybe a C1, 2?
And I think the question is, so we've, as I said, we've been looking into this, and our goal is to try to identify specifically, we only do whatever level seems like it is their worst level. So if it's 01, if their worst inflection, like there's some people who they basically feel like they're gonna pass out when they go look down at their phone. Those are people we just do an 01 on. And then, so it's, if they really have both sets of symptoms, then they're the 02s. And right now, as you saw, that only made up, a quarter of our group so far. I believe me, I hear everything you guys are saying about don't get yourself pigeonholed as a crazy guy. And so that's why I have my research people. So the one issue we have with the dynamic CT is the radiation dose. And so as it is, I have the protocols for the people that are the facilities that are doing these for me. We'll get a CT scan, a neutral CT as baseline. Like nobody goes into the second tier. Then we get a specific rotational CT, and you have to tell the patient and the radiology facility, if the head isn't maximally turned, it's a useless study. They really have to go all the way around, and nothing that the head gantry holder, none of that can limit them. They have to be positioned in a way that keeps that. And I've had patients go back and get it done again, which is now doubling their radiation dose. And so just for this particular study, we only scan from C4 to the skull base. We don't scan the whole spine just to try to reduce the amount. For the same reason, I did the first few as CTA, CTV in rotation. And that's a huge dose of both the contrast, because they want to do each side individual injections, and then the radiation exposure.
Another modality that might reduce radiation, I don't know, is the Z fluoro. So we now have intraoperative fluoro that's capable of reproducing essentially a CT.
Right.
And so that modality may reduce the radiation exposure. It's just fascinating stuff.
All the time is absolutely fascinating, and I actually agree a lot with what you're thinking, and I can see where you're going. It makes complete sense. But yeah, a couple of comments though. One is on the flexion extension view of radiology. You got to establish, I would say at least establish a normal baseline. We don't know what happens to you and I when we turn. The thing will be the reality to you, it doesn't matter to us. And that happens flexion extension MRI. There's a lot of things that happen that we don't know. I said that probably we need before you say, okay, this is abnormal, like there's something happening. But the question was more about the C2 nerve. What about the headaches? Are these headaches different from the greater occipital headache? And what about the C2? Does that get involved? Is that part of this whole spectrum? We see a lot of that. You see the headaches when people with C2. Hypermobility. You see it in Down syndrome. I just had a patient Down syndrome a few weeks ago. Right. Right. I just started C2. Right. I don't think we think a lot more now. Yeah. But I just want to know what your correlation is.
So I think the vast majority of these, I don't think the C2, unless they already have a history of getting a C2 block and doing well with it. Many of these I'm actually not taking C2 nerve at the time of surgery. I've actually started doing these as a combination of screws and cables, sometimes multiple cables. Like I'll do a screw at C2, and then I'll do a cable on either side of C1 to pinch it down. And then I might even do a third cable in the middle across from the arch around the spinous process, kind of like old school. But I won't necessarily take C2 unless they've already also had, like they have a specific occipital nerve distribution of pain.
Right, that's what I was asking.
Many of these, their headaches start in their face. Okay. They start in their head, they start in the front and go back rather than the back of the head going up into the C2 distribution. So, and when they do, we'll do the C2 blocks first and see if we can take that off the plate and have it not be part of the discussion. But I love the idea of looking into that venous outflow. I've actually been working with vascular surgeons on things like May-Thurner syndrome and TOS, and they've been looking at all these different collateralization and the Batsons and the other peridural venous, and we all know when we get into C2, it's a massive venous plexus there.
We were actually quite shocked by that finding because we always thought it was going to be the jugular system. Turns out not to be.
Right.
A really great talk. I was absolutely not a believer in CCI. until I had a patient in clinic with the exact same pain diagram. I gotta admit, I kinda did an eye roll and handed it to my fellow who's from the University of Iowa. He worked her up, put her in a collar, she felt better. We actually sent her to Iowa for a fusion, and is like so happy for an Otis infusion. So, really interesting work. I think you're gonna turn a lot of heads.
I think the pun was fully intended, and I think you're planning on it.
Thank you so much for coming out here. This was a really great talk.
Quick question.
Yes.
Out of all your patients, they're all females, or is there
Oh,
any
no.
males involved?
Oh, yeah, no, there's males.
What ratio is that?
It's probably 2 to 1.
2 to 1.
2 to 1 in my surgical group, which is still a relatively small group.
And your primary data points are the pain use, or your...
No.
So what are those
So the primary data points are memory function. Brain fog is a specific separate complaint that we look at. Is it better post-op as well as compared to pre-op? They often get these visual changes, and the problem is usually blurriness because. And I have one patient whose symptoms we actually were able to track them, and you could see pupillary size, and pupils got bigger. And that's when the blurriness came on. So this is truly they're getting an intermittent corner syndrome. So we're looking at that incidence as well. And then neck pain and other GI symptoms. It's shocking how many patients with IBS or gastrointestinal complaints, they say, by the way, my GI symptoms are now better.
Also, clinically, can you reproduce that in the office? If you don't get that, do they get those symptoms?
Yes.
In the office?
Yes. Usually, sometimes we have to have them hold it for a little bit, but yes, they're like, or some of them be like, I really don't want to do that. And I'm like, well, I just humor me and let's see that. I also had one patient who we put her in a collar, and initially she didn't get much benefit from it, but I also noticed she was kind of swimming around in her collar. And she actually had dilated pupils. And we did this light testing, I dimmed the lights and I did the pupillary testing. And I tightened up the collar so she couldn't move around in it anymore, and her pupils got smaller. I mean, I would love to get more people involved in this process and more data from more centers involved in this process, because I think that this is, as you said, A, I don't want to be seen as an outlier, but B, I think we could help a lot of people.
I don't know if you have an answer to this or not, but we who don't have hypermobility syndrome get arthritis as we age and our motion decreases.
Correct.
I don't know if people with hypermobility syndrome do the same thing, but have you noticed if these are all young patients and maybe they get better as they age?
These range from 20 to 50. Obviously, I'll be following their range of motion over time because they're already hypermobile.
Yeah.
Most of them don't notice a huge drop in their range of motion post-op. They still have usually at least 45, 50 degrees range of motion side to side from the other 6 motion segments below. And so it's not a huge impairment to them to do this.